For those of you who don't know me, I'm Dr Leen. I'm an internist and clinical pharmacologist and toxicologist. This week is our clinical pharmacology medical grand round, so I'll be talking about buprenorphine inductions. Today, we'll review the neurobiological model of addiction, understand the changing landscape of opioids, review specific key properties of buprenorphine, and go through different induction protocols that exist and understand how to choose the most appropriate one. So here I have several cases, very similar in nature, being referred for opioid agonist therapy initiation. So we have a 54-year-old man with chronic pain on quite a bit of hydromorphone who comes to you in withdrawal, so a COWS or clinical opiate withdrawal scale score of greater than 13. Or he came to you not in withdrawal. So we'll look at both scenarios. Similarly, instead of hydromorphone, patient comes to you who uses methadone and is not in withdrawal. And finally, a fentanyl user who either comes to you in withdrawal or not in withdrawal. So we want to know, are all these candidates for buprenorphine? Whoops, sorry, I lost my view. And if so, how will you initiate? Sorry, I think my screen is frozen. I'm gonna have to stop sharing just a second. So opioid addiction is quite prevalent. In fact, 8 to 10% of people exposed will become addicted. It's a chronic relapsing behavioral condition that occurs over time, and you can't just stop a drug and expect patients to stop their addiction. There is DSM-5 criteria for opioid use disorder, so we can label these patients with the disease if they demonstrate problematic pattern of opioid use that leads to significant impairment in their function. So most of the criteria can be categorized in these main categories. So criteria that exhibit impaired inhibitory control, so you can't say no and you want to keep using. Criteria that involve cravings, an obsessive compulsive type of use that leads to functional and social impairment and risky use, and pharmacological properties like tolerance and withdrawal. So if we look at the brain more closely, there's 4 key brain circuits involved in addiction. In the non-addicted brain shown here, you have control, overseeing the other 3 brain circuits. So the drive to use, the feeling of reward when you use, and the memory of the use. And that control aspect is very important because in the non-addicted brain, you can stop your use. You can say, no, I don't want to use anymore. Whereas in the addicted brain, you lose that inhibitory control and you can't say no. And so this is how addiction becomes a learned behavior that rewires the brain, and it's primarily driven by dopamine and the reward of use. And memories and cues can trigger this cycle as well. Looking at the neuroadaptation that takes place over time, addiction moves through these three stages. You have the binge intoxication stage when you use, you have the withdrawal and negative affect phase when you stop using, and then when you think about using, you have the preoccupation and anticipation. So at the beginning of the disease, it's very impulsive use and very emotionally driven. And most patients use to feel good. Then over time, you get reduced excitement, you start to feel less good, and the use changes to compulsive use. And most patients use in order to avoid withdrawal and to avoid feeling bad. And so the brain needs to take time to unlearn those behaviors. And that's why if maintenance therapy is not started, then stopping a drug cold turkey has very high relapse rates. So this is coroner data that looks at deaths in Ontario in which opioids were identified. You can see that after 2016, the deaths that involve opioids have gone up significantly. And what opioids are found in these patients? It's an increasingly large amount of fentanyl and fentanyl analogs. You can see here that almost 90% of those deaths involve some type of fentanyl. And that's in contrast to the regulated opioids or prescription opioids, where they're only found in about 10% of deaths. So the landscape of opioids is changing. We're seeing a lot more fentanyls, a lot more high potency fentanyls, deaths involving fentanyls, hospitalizations involving fentanyls, especially in this young male population. So the previous way in which we started opioid agonist treatment, those types of strategies may not work in this specific new population. So one thing that makes it complicated is the significant opioid tolerance that develops in these users. So most fentanyl users will quantify their use in points. So 1 point of IV fentanyl is approximately equal to 0.1 grams of fentanyl. And clinically, that's thought to be about 32 to 50 milligrams IV of hydromorphone. And most users either use 3 to 4 points a day, and some upwards to 1 to 2 grams per day. So that's quite a lot, because if you do the conversion, about 1 gram of IV illicit fentanyl is about 320 to 500 milligrams of IV hydromorphone. And if you want to prescribe that in hospitals so that these patients don't lose their tolerance and don't go into withdrawal, you're looking at 40 to 60 milligrams IV, Q3 hourly, or 80 to 120 milligrams PO, which is a lot. So that's where opioid agonist therapies come in. In Canada, we have clinical practice guidelines to manage these patients. And the first recommendation is that buprenorphine and methadone both can be used and are considered both equally to be first-line treatment options. It's just one part of the continuum of care for these patients, and we'll just be focusing on buprenorphine. And specifically the sublingual preparation. We'll see later on that there's other forms of administration, but I just want to highlight a few properties of the sublingual preparation. So the absorption is quite poor orally, so that's why it's given sublingually. And the most common preparation is Suboxone. So it's buprenorphine and naloxone together. The naloxone component is not active because it's not absorbed PO or sublingually. It's there to deter intravenous use of the medication. The onset of activity is within 30 to 60 minutes of administration. And that's important because this concept of precipitated withdrawal can occur within that time frame. And it is the limit to how frequent you can give this medication, Q1 hourly. It is subject to a number of drug-drug interactions as it is metabolized in the liver. It is a CYP3A4 substrate, so it is subject to 3A4 inhibition, which may increase buprenorphine levels, or subject to reduction in levels if there's concomitant use of a 3A4 inducer. Its elimination is through the feces, and it has quite a long half-life. So it is amenable to alternate day dosing, but we can see that, we'll see later that there are other preparations that lend itself better for those who may not be compliant. So looking at the pharmacodynamic properties, what makes buprenorphine unique is that it's a mu opioid receptor partial agonist. So it has a limit to how much respiratory depression it can exert when it binds to the mu opioid receptor. The second key property is that it offers a blockade. So when it binds to the receptor, it binds very strongly, and it's slow to come off of the receptor. So because of that, and we'll see later that there's a risk of this thing called precipitated withdrawal, but it works well and it works very fast. Another property I'll highlight is that it is lipophilic, so it can be stored in the fat tissues and creates a reservoir of the drug. I'll just briefly mention that it's also a kappa opioid receptor antagonist, and it's thought that kappa antagonism makes patients feel less unwell during withdrawal. It has a whole host of other effects, but we'll just be primarily focusing on the mu opioid receptor effects. So looking at this in more detail, we have a figure here that illustrates partial agonism. So on the y-axis, you have the effect of the binding of the drug to the mu opioid receptor and the agonism. And on the x-axis, the dose. So full agonists like heroin, like fentanyl, when the drug binds to the mu opioid receptor, you have all of the spectrum of mu opioid receptor activation. So euphoria, sedation, analgesia, respiratory depression. Partial agonists, like buprenorphine, when it's bound, it only provides partial agonism. So again, a limit to how much respiratory depression it can exert. And in that way, it's thought to be safer compared to the full agonist opioids. Antagonists like naloxone, when bound, they exert no agonism. So this equation represents all ligand receptor interactions. So the ligand plus the receptor is in equilibrium with the ligand receptor product. And it's a constant state of flux where the ligand binds and unbinds from the receptor. This inhibitory constant Ki, it quantifies the binding affinity of that drug to the receptor, in that lower Ki drugs have stronger binding affinities. Buprenorphine has one of the lowest Ki's, so very, very strong binding affinity, and again, slow dissociation at the opioid receptor. And that's important because when it's introduced to a patient, it will displace most opioids that are bound already. And secondly, it will block most opioids from binding after it's bound. And I just put the Ki's of representative drugs here, and you can see that the Ki, or binding affinity of buprenorphine, is similar to that of hydromorphone. So in the situation where you need to treat patients on buprenorphine who have acute pain, this is why hydromorphone is the most appropriate drug because it can compete off buprenorphine. So this concept of precipitated withdrawal, it results from partial agonism and the blockade properties of high binding affinity and slow dissociation. And that's illustrated here. So in comparison to a full agonist, when bound to the mu opioid receptor, which activates the receptor fully, buprenorphine, because of its partial activation, is a relative decrease in agonism. So that in some patients is experienced as withdrawal if you give too much of the medication all at once. And just briefly, buprenorphine is lipophilic, and that can mean that there's easy brain penetration because the brain is quite fatty, and slower elimination. It's actually quite similar to methadone and fentanyl. And we know fentanyl and methadone, they both create reservoirs of the drug in patients over time who are chronic users. Reviewing adverse reactions, it has the whole spectrum, again, of mu opioid receptor side effects, but less so in terms of respiratory depression. And most commonly, patients may complain of a headache, which does get better with time. Contraindications are listed here. I won't go into them in detail. And then just looking at buprenorphine, what we have in Ontario and what's covered on ODB. Most patients can't pay out of pocket for this medication, so reviewing the ODB criteria is important. We do have Suboxone in tablet form. The criteria implicitly assumes that methadone is first line, so they're a bit outdated. And they specifically say that the prescribing physician should have some training in prescribing this medication, though you don't need a specific license. Sublocade is the other preparation that we'll review as well. It's the depot or injectable form of the drug. It is not compounded with naloxone, it's just buprenorphine alone. The other two preparations are an implant and a transdermal patch. So in summary, buprenorphine is unique because of its agonism effects and its blockade effects. So the agonism effects are thought to help control cravings, control withdrawal symptoms, and then the blockade effects block the reinforcing nature of the use and the drug liking effects. And hopefully over time with continued use that translates into improved clinical outcomes. So OAT is important to offer to hospitalized patients. These patients are vulnerable. They only present to hospital when it's absolutely necessary. And we know that initiation can improve compliance with medical treatment, improve patient comfort, and hopefully also reduce mortality and other important outcomes. So there's different ways that we can start this medication, and I'll review them. We have the standard induction, and then off-labelly we have micro dosing induction and macro dosing inductions. So standard induction requires prerequisite opioid withdrawal, meaning that patients who are chronic users need to stop using beforehand to ensure that there are some receptors available and open for buprenorphine to bind to. The suggested times of discontinuation are listed here for short-acting to long-acting opioids. And for methadone specifically, they say that improved success to transition to buprenorphine is best if you taper all the way down to 30 milligrams. And we're aiming for moderate withdrawal, so a COWS score greater than 12. And just to review, the clinical opiate withdrawal scale is summarized here. You have different criteria, just like the CWA, to measure how significant the opioid withdrawal is in the patient, both objective and subjective criteria. So an example of a standard induction day one, you wait for the patient to go into withdrawal and you give them a dose of Suboxone. The suggested dosing per monograph is 2 to 6 milligrams, and it's variable because you can choose a higher dose if the patient is in more withdrawal or a lower dose if they're elderly. And we know that the onset of this medication is within 60 minutes, so we can't dose any more frequently than Q1 hourly. So after the first dose, the two clinical pictures could look like this. The patient could be in no withdrawal, in which you can just prescribe that day's dose on the second day and continue titration, or with consent, or if the patient is in withdrawal, then you can administer additional doses Q1 hourly. Again, the clinical picture will look like the patient is in no withdrawal after you give additional doses. If so, then you can just prescribe that the following day, or they could be in withdrawal. And if you reach the daily maximum, then you treat them with other non-opioid medications to treat the withdrawal. And these maximums are really arbitrary, but if you're by the book, the day one maximum to give a patient in the monograph is 12 milligrams. And according to the CPSO, it's actually 8 milligrams, so even lower. And the day two maximum is 16 milligrams. So this is an example protocol where they started off with giving the patient 2 milligrams, and then over the next subsequent 3 hours, they got all the way up to 10 milligrams. It is possible for patients to, again, develop precipitated withdrawal. And the difference between underdosing versus precipitated withdrawal is very gray, but the treatment is the same for both. And you can either continue on with consent to titrate to a dose that alleviates their symptoms, or you can treat them with non-opioid adjuncts. You're aiming for a maintenance dose that controls cravings and withdrawals for at least 24 hours. Again, the monograph says that the first week target dose should be 12 to 16 milligrams. The Canadian maximum dosage for daily dose is listed as 24 milligrams, and specifically they say that there's no further advantage beyond 24 milligrams, but we'll see that that's quite arbitrary. If you think about any other opioid, there really is no maximum amount. You'll be limited by respiratory depression first and foremost. So this statement here isn't supported by evidence, and that's why these other protocols have developed. And we know that in the United States, their daily maximum is 32 milligrams. So we have a lot of experience to going up to at least 32 milligrams. But this prerequisite opioid withdrawal and possible precipitated withdrawal is a deterrent for a lot of patients. If you tell a heavy user to stop their use and come back in 24 hours, they probably won't be able to. So we need protocols that, again, obviates the need for prerequisite withdrawal and limits the risk of precipitated withdrawal. And that's where microdosing inductions come in, also known as the Bernese method. So this is where we administer small doses of buprenorphine over time. And the theory is that buprenorphine will bind any unoccupied mu-opioid receptor because of its strong binding affinity. And because it slowly dissociates, it will eventually replace the full mu-opioid receptor agonist. Key points is that you don't have to be in withdrawal to start buprenorphine this way. So your CAL score can be 0. It does take several days because you're slowly introducing the medication over time to replace the full agonist. And patients like the fact that they can continue their full mu opioid receptor agonist. It is suggested that you stop it at 2 minimum buprenorphine doses. So if a patient's on short-acting opioids, then at 4 milligrams, you would stop their agonist, and at 12 milligrams if long-acting. This is to help facilitate the transition process and, again, reduce the risk of precipitated withdrawal. Our goal is to titrate them to a therapeutic dose, and for opioid use disorder, that's greater than 16 milligrams. So who is best suited for this kind of induction? Well, it's patients that cannot go into opioid withdrawal. So that's the elderly, patients with cardiovascular or respiratory comorbidities, or patients that just don't want to go into withdrawal. And those that are on long-acting agonists but are not in withdrawal. So I just will show you a few induction protocols. Because it's off-label, people are figuring out the best way to induce patients. And so there's a variety of protocols out there, both in terms of frequency of buprenorphine administration, whether patients are on short or long-acting opioid. So here we have 2 sample protocols, both lasting about 7 days and both indicating when to stop the other agonist. And here, this example of a protocol makes the distinction between patients who are on short-acting opioids versus long-acting opioids, and again, when to stop their concurrent full agonist. So that's great, but microdosing is unlikely to be effective in high-potency fentanyl users. The reason is that it's very slow to get patients onto buprenorphine and to get them therapeutic. And fentanyl user is not gonna wait 7 days. As well, because of this reservoir of fentanyl in their system, they're at somewhat higher risk of precipitated withdrawal. So these users need protocols that administer high doses of buprenorphine and protocols that can achieve therapeutic dosing very quickly. That's where macrodosing comes into play. So macrodosing just refers to going above this arbitrary day 1 maximum of 12 milligrams. This group did a scoping review of all high dose initiations that have been published up until 2024. And they summarized them, and they found 15 studies and 580 high-dose inductions. One caveat is that it didn't really include fentanyl users, but I'll just show you some of the data here. Some of them were in mild withdrawal at the time. The purpose of showing you this is to let you know what sort of single doses they gave patients. So these are the randomized controlled trial protocols. And you can see that patients were given very, very high doses, so 32, 64, 96 milligrams, all in one shot. Others received 16 or 32, and this study gave a total of 40, but divided into 2 doses, 8 and 32. And overall, it was very, very safe. So there was no reports of any fatal or non-fatal overdose or respiratory depression. The main side effects were actually nausea and vomiting. And there was some reported precipitated withdrawal, which is to be expected because of what we know about the drug. So this is growing evidence that suggests that we can safely relax that arbitrary day 1 maximum of 12 milligrams. So the goal is to get patients to a therapeutic dose We know from the literature that all the studies studied buprenorphine at doses greater than 16 milligrams, and that translates to a serum buprenorphine level of 2 to 3 nanograms per mil. We know that some patients, particularly fentanyl users, may require an even higher average concentration of 5 to 6 nanograms per mil, but 2 to 3 nanograms per mil minimum is what we're targeting. And that seems to correspond to 70% occupancy of receptor. So this data is taken from the Indivior Pharma website. And you can see here that we have buprenorphine plasma concentration on the y-axis and different doses of transmucosal or sublingual buprenorphine on the x-axis. And at each dose, they published the average concentration, the C max, and the C trough. And indicated in the blue line is that therapeutic threshold, that 2 nanograms per mil. So we want to have patients have a serum level above this to be considered therapeutic. And you can see that the C average, it doesn't cross the 2 nanogram per mil threshold until at least 16 milligrams. And even then, you can see that the C trough sometimes goes below the 2 nanograms per mil. So it's not consistent. Some patients may need even more than 24 milligrams. That's where the extended release depot injection or Sublocade comes in. You can see that at steady state, the 100 milligram and the 300 milligram preparations both provide C average greater than 2 nanograms per mil and C trough greater than 2 nanograms per mil. So pushes these patients therapeutic and reliably therapeutic. But how do you start patients on this medication? Well, according to the drug monograph, the typical induction occurs after taking 7 days of sublingual buprenorphine. Then you would give a 300 milligram subcutaneous injection times 2, separated by 4 weeks, and then maintenance therapy of 100 or 300. This shows you again the mean plasma levels and the threshold of 2 nanograms per mil after the standard initiation period and then the maintenance period of either 100 or 300 milligrams. And you can see that after the initiation period in both dosing protocols, you're above 2 nanograms per mil quite reliably. So this begs the question, can we shorten the induction period onto Sublocade even further and sort of get rid of this minimum 7 days of sublingual buprenorphine? We know that the extended release serum levels do peak after 24 hours, so you will be well within that therapeutic threshold, over that therapeutic threshold after 1 day. So at minimum, we can start to think about single day inductions. So that's what they looked at here in 2021. They published an open label trial of single day inductions onto extended release buprenorphine for heroin and fentanyl users. They only looked at 5, and the addiction data is always small and mainly limited in many respects, but these patients abstained for 16 hours. They had some withdrawal, again, to minimize precipitated withdrawal risk and to open up some receptors for buprenorphine to bind to. And then they induced them Q1 hourly on the first day, and they gave them a total of 24 milligrams. And if they weren't sedated, they would give them the 300 milligram dose, and these patients could be discharged. And then they looked at whether they were retained into treatment, so the treatment being the next initiation dose and then the maintenance doses, and 100% of them were retained. So this shows the more evidence for single day inductions. This group is from Ontario, and they published how they put patients on Sublocade who were fentanyl users. So we have a case of a 26-year-old female who uses 0.5 to 0.6 grams of fentanyl a day and came in some withdrawal and was given a total of 28 milligrams day one. And then day two, they gave them 32 milligrams max and onto the Sublocade, and it was tolerated well. Similarly, an even more heavy user, 1 gram per day, came in withdrawal, started on a little bit of sublingual buprenorphine, and then day two onto Sublocade with, again, minimal side effects. The largest collection of data so far for single day inductions is from this group in Timmins, Ontario, where they reported outcomes for 98% fentanyl users in 99 patients. So these patients presented in the emerge and were admitted to an inpatient withdrawal management. And they were given sublingual buprenorphine first, as usual, a mean dose of 35 milligrams, and then median of maybe 2.5 days onto Sublocade. And no adverse events were reported, so including precipitated withdrawal, which is quite exciting for this patient population. And then the treatment retention at 3, 6, 12 months steadily declined, but that's not to be unexpected. But the main point is that they actually published that there was reduction in healthcare utilization by getting patients onto treatment. So they showed that there was a reduction in non-fatal overdoses, emerge visits, hospital admissions after intervention. So how do we choose the most appropriate induction strategy? We know that the goal of induction is to provide enough buprenorphine so that we can provide enough agonism and block further binding to relieve withdrawals and cravings. We know that that translates into a serum level of at least 2 to 3 nanograms per mil. We can achieve that either by giving patients at least 16 milligrams of sublingual buprenorphine, or after 2 doses of 300 milligrams subcutaneous. The main questions to ask when we're choosing the most appropriate strategy are related to the properties of what they use. So we can make a distinction between fentanyl users and non-fentanyl users, and getting an idea of when they last used. There are other patient factors, and the most important one is to determine whether the patient is in withdrawal or not in withdrawal. And then the absolute dose of buprenorphine. So this group in 2022 published this figure sort of summarizing when it is clear to use either strategy. So on the x-axis, they reported an opioid balance for patients. So the pre-induction opioid balance. So it can either be negative, where you have a predominantly, you have mu opioid receptors that are primarily unbound, or a clinical picture of withdrawal. If that's the case, then macrodosing would be most appropriate. Or you can have a clinical picture where patients are on their full mu agonist and the receptors are bound. And in that case, it would favor the induction via microdosing. Macrodosing also favors patients who use fentanyls versus microdosing, where they opioids that are more easily displaced or non-fentanyls are favored. But we do need adaptive induction protocols, because fixed dose protocols or following a protocol line by line often leads to subtherapeutic dosing, especially for high potency fentanyl users. And they're particularly at risk because if they if they leave hospital or they stop the induction midway through, then you've basically opened up some of their opioid receptors. And if they use again the same amount that they usually use, they're at risk of overdosing. So we need to be able to adapt, and that does come with clinical experience. So just looking at the cases again, are all these patients candidates for buprenorphine? Yes. If so, how will you initiate? So those are our cases. So again, the key considerations are you want to distinguish between a fentanyl user and a non-fentanyl user. If it's a fentanyl user, most likely a macrodosing approach would be most appropriate. If they're non-fentanyl, then a microdosing or standard approach may be most appropriate. The next consideration is if they're in withdrawal or if they're not in withdrawal. So whether they have a negative opioid balance or unbound opioid receptors for buprenorphine to bind to. If they're in withdrawal, then a standard or macro induction would be most appropriate. If they're not in withdrawal or COWS score of 0, then micro. And if they go into precipitated withdrawal during any of these inductions, then changing to a macro strategy would be most appropriate because you've displaced a lot of the opioids and the receptor is open. So you want to replace it with buprenorphine. So you change to a macro strategy. So again, looking at these cases, we have a patient who's primarily on a non-fentanyl who's in withdrawal. So probably a standard induction would be most appropriate for a patient. If he was not in withdrawal, then a micro-induction. For a long-acting non-fentanyl opioid user who's not in withdrawal, a micro-induction. And then for a fentanyl user who is in withdrawal, a macro induction, or if they're not in withdrawal, you can either, probably the best strategy would be to wait for them to go into a little bit of withdrawal and then macro induce them. So the future of buprenorphine, we will see more of it in practice. I know in my training, at least, I never heard of these medications until fellowship, even though it's been around since the 70s. More healthcare providers are becoming increasingly more familiar with buprenorphine, and the RAM clinics across Ontario are prescribing these medications. And you might see it in two forms, so low dose buprenorphine, so less than 8 milligrams. Usually patients are on it off-labelly for chronic pain. And especially if the ODB coverage indications changes to include chronic pain, we'll definitely see it a lot more. And then you have the high dose users, so those who have a history of OUD and who are on it for maintenance therapy purposes. So the take-home points are that buprenorphine and methadone are first-line therapies for opioid use disorder. And the high-potency fentanyls are changing our understanding of how we should be inducing these patients because of their high tolerances. Buprenorphine has unique pharmacologic properties that favor its use, specifically the partial agonism and the blockade. And there's increasing clinical evidence that supports off-label inductions, either micro-inductions or macro-inductions. And these strategies are promising to get patients onto treatment and retain them into treatment. So that's the end of my talk. Just a reminder that clinical pharmacology and toxicology is a consultation service that you can consult via Epic. And myself and Dr. Chris Lazongas can provide consultations on a number of topics listed here. So I'll just stop here and I'll take any questions.
Hi, Jessica. It's Grant here. Thanks. Excellent talk. I had 3 questions. I put in the chat, but the first question was, and I might have missed this, is that in a patient who hasn't been on any OAT in the past, and you want to initiate them, like how do you decide between methadone and Suboxone? Second question is someone who's been on methadone. You mentioned transitioning to Suboxone, but you need to titrate the methadone down to a certain level. Is that always the goal when you start someone on, when someone's on methadone? Is that the goal to transition them to Suboxone or more of a partial agonist? And then the third sort of the follow on that is that do you keep patients on this, or is the goal ultimately to titrate them off completely of everything? And the last question, which you brought up, which is off-label use for chronic pain, do you foresee Suboxone supplanting all other opioids for chronic pain due to its properties?
Um, okay, let me know if I missed any of the questions. You might have to repeat some of them,
Sorry.
but
Sure.
the first one is how do you decide between methadone and Suboxone? So both are considered first-line treatments, and you're not wrong if you start either. The issue with starting methadone and the limitations are that you have to start it slowly, and it takes a long time to get therapeutic. So if you have time, like this is an inpatient that will be admitted for a long period, it might be more better to start them on methadone. The literature before did favor methadone for IV drug users, mostly heroin users, but now with this new data, with Suboxone and Sublocade in IV fentanyl users, the pendulum is sort of shifting to buprenorphine. So more commonly now will you see patients wanting to start Suboxone, but you have some of the older opioid users that all they know is methadone, and they have a preference for that. The other issue is that in the first month of starting, methadone is the highest risk for overdose. So it is still, again, considered a very high risk medication that needs to be titrated under very close supervision. So there are different factors in which you can go through to decide whether methadone versus Suboxone, but the overall growing evidence is starting to favor buprenorphine just because of the ease of initiation primarily. Second question was
Titration, shifting to methadone to Suboxone, but like, is that the goal? And then
oh yes,
secondary goal being weaning off completely, sort of like, weaning it off completely.
right. So patients are on these medications chronically because it does take time for their brain to, again, unlearn those addictive behaviors. So, really, agonist treatment should be prescribed in conjunction with the other psychosocial treatments, either psychiatry, follow up for diagnosis of any underlying mental health disorders, um, uh, connection to social services to offer stabilization in social aspects like housing, occupation, job, things like that. So it's just one part of the piece. And eventually, the goal is for patients to titrate off of the medication, but it's not uncommon that these patients are on these drugs for years. And some patients prefer to be on these drugs long term because they associate it with stabilization in their lives. But the goal is to get them off of it eventually. And telling patients this up front does make them more likely to engage in treatment. And if a patient is on methadone, you don't necessarily need to change them to Suboxone. But as that patient population gets older, we see more difficulties with continuing methadone because of changes in body fat storage, liver health, things like that, where it would make sense that they be switched to Suboxone or buprenorphine. So there are some methadone users where they do end up changing to Suboxone for other reasons, but you can continue either first line therapy for the duration that is needed to, again, change their or rewire their brain. And was there another question?
The last one was just in the future, thinking of
Oh,
this as like, this sounds like an amazing opioid, like in terms of lots of great properties. Do you
yeah.
foresee it replacing other opioids or most of the opioids to hopefully prevent addiction
Yeah,
in the future?
it's hard to say, but I think that its popularity is increasing, at least in the past 10 years. There has been more interest in it because of its relative safety, compared to other full agonists. We are transitioning patients off labelly, those that have chronic pain, because of that safety profile. And again, as the population ages, I suspect that more interest will be in changing patients from all the side effects of full agonists to buprenorphine. It is something that is it's something that is of great interest to a lot of people, but again, it remains off label. So I think that's what deters a lot of providers from making the switch. And even those who are experienced in prescribing buprenorphine, they've only learned to prescribe it uh, for patients with opioid use disorder. So the chronic pain population is a bit different. Their opioid requirements and their opioid tolerance is a lot lower. So that's where microinduction is going to become more popular. We will see patients being started on those medications through that induction protocol. So I think it will be something that we will see more of in the future. It's just, if ODB can cover this medication for chronic pain, we'll see it. And as patient providers become more familiar with the medication, we'll see it. So the future is very bright for this medicine.
I think there was a question in the chat about cancer pain or use in cancer pain.
Any use in cancer pain? Yes, so the patch is approved for pain and chronic pain. So but the doses of the buprenorphine are quite low. So certainly it can be used in cancer pain, especially in that specific population. So yes, it has been used, but it's not very popular. I'm not sure why. I think it has to do with our familiarity with the drug, and we are just not taught enough about it. I think in training, and that's probably the main reason. But yes, it has been used in cancer pain. Any other questions? Okay, if there's no further questions, thank you all for attending, and please attend the social this evening at Venu's house.